in terms of extrovert, it is just selecting full denture. So the upper arch and the lower arch, they become full dentures. In terms of tree shape, you select the upper arch and the lower arch as artificial tooth, as well as the gingiva becomes denture gingiva. Once this step is done, then you go ahead with the designing on the software, which I'll be showing you once we are done with this presentation. So once that design is done, what we like to do is take a trial of this denture that we've designed and go ahead and do a draft trial. So this is exactly equivalent to the trial of the denture that we do in a patient's mouth, except there is no wax. There is a 3D printed resin that we do a trial of. You check everything that is possible that you check during a trial at this draft trial stage. And if there are any corrections, then you mark them on this draft trial so that you can transfer it to the design, make the adequate corrections that are needed. If there are a lot of corrections that are required, then you repeat a draft trial again. If there are not many corrections, not much changes that are required, then you continue and go ahead with your final prosthesis. So in this case, we gave her a milk denture. So this is an Ivosian's blank that comes in a single blank of pink as well as the white part, and it gets milled. So post the dentures are milled, this is how the finished product is. The finished prosthesis, wherein we've done indirect composite layering, because a milled denture, no matter how pretty it may look, it will require some amount of gingival characterization, because our gingiva is not one shade of pink. It has different shades of blue, red, dark browns, pigmentation. So based on the patient's requirements, we will have to go ahead and characterize the gingiva accordingly. And this was the final result where we given the patient the milled finished dentures. Now we also have another case of a printed denture. So this was an aspect of a milled denture. Milling in terms of complete denture is a slightly more expensive option compared to that of printing. However, it is a slightly more aesthetic and a more stable option. So this is a small video that we had prepared for a 3D printed complete denture. So in this case, the patient had come with an existing denture set, but she came demanding for a printed denture. She wanted a digital denture. I think she had gone through Google and she read about digital dentures, and while she visited our clinic to get a set of digital dentures. So because she already had a set of dentures, what we did was go ahead with a procedure called as copy denture. So because her vertical dimension, her jaw relations were all perfect with the existing denture, we went ahead and we scanned the existing denture. We printed a set of copy dentures so that we could go ahead and take impressions of the same. So this is how the copy dentures would look after they are printed. Then we checked for the movements and we went ahead with the secondary impression as well as the jaw relation. Once that was done, then we go back to the same steps that we had done earlier. We take a scan of the upper and the lower impressions and take a scan of the jaw relation as well. Once that is done, you go ahead with the designing procedure, the steps that are required for designing, and then you have your design denture ready. However, in terms of printing, both the pink and the white get printed separately. So first we went ahead with the printing of the pink part of the denture. And then we went ahead with the printing of the teeth set. Once that is done, the printed teeth are to be washed with IPA, then they undergo a cycle of curing. And this is how the final dentures are with indirect composite characterization. So this was just the clinical workflow with that of the complete dentures.
How do you join these two parts together, the pink and the teeth?
So ma'am, there are adhesives that are available, but you can also use the denture, the printing material as such. You can apply layers of that and then cure it, light cure it, and then they adhere together. That is how we can done it with these cases.
So the resin itself is technically a bonding agent.
Yeah.
So
the printing resin.
Yeah, so it cures under light. So physically, when the machine is working, light projects and it gets cured in layers. So that same resin you can add on full layer of resin, just like you add cement on anything, and press and cure. So when it gets cured, it bonds to tooth surface and gingival surface together. But you can also use resin cements in clear acrylic bonds, anything you can even use clear acrylic itself to bond.
Because it's PMMA, so it will adhere to each other. Next, we have a case of a.
The event of rebonding of a tooth or fracture of the denture is how are the procedures different from the conventional tooth?
Ma'am, at the end of it, it is a PMMA only, it's acrylic only. So the relining can be done with that of the chairside acrylic or the self-cured acrylic as well.
Not for the relining part of the fractures.
Same thing, ma'am. The fractured area, we can join it together, and how we go ahead with the correction of the fractured parts, we go ahead with that.
Conventional material will bind.
Conventional material binds to it, yes, ma'am. So we move ahead with removable partial denture. So this is a patient who had come to us with the history of mucormycosis, and we had gone ahead and surgically done the removal of the infected regions, and this is the defect that was present. So in his scenario, our initial plan was to go ahead with the removable partial denture. So what we did was create the rest seats, go ahead and take an impression of the same, and then transfer it with the help of a lab scanner and create an STL of the same, and go ahead with the designing. The designing part of this we will be going through while we are going through with the designing protocol. And then we made a removable partial denture. So this is how the design would look after the casting. So again, two things can happen. One, we can print it using DMLS. You can print the cast partial denture immediately, or you can do wax milling and then cast it again. So this is how the cast partial denture was. In this patient, this cast partial denture lasted for almost 3 years, and then the patient wanted a fixed option because of his age. He came back to us saying that now I think I'm ready for a fixed option and I'd like to go ahead and explore my options in terms of fixed option. So we went ahead. What we had initially decided was a patient-specific implant, but then the patient was not ready for another round of surgical aspect. So what we did was go ahead, take impressions. We prepped the posterior teeth. We took a set of secondary impressions for the same, did a jaw relation. And yesterday we were talking about a tooth-supported eye bar. So what we had planned for this case was a tooth-supported eye bar, with which there will be PMMA attached as a superstructure. So we went ahead, did a jaw relation for the patient, and then we created a draft trial. But if you can see in the draft trial, we've done a few markings because there were issues with the midline, there was issues with the exposure. This is how the patient looked post the draft trial. So we were not very happy, the patient was not very happy with how the aesthetics looked. So we went back again, made certain changes to the existing draft trial that was. And then, but with the draft trial, we understood that the fit of the prosthesis was okay enough. So we went ahead and we created the bar. We use the Blender software, separate the two, the gingival part as well as the tooth part. With the gingival part, we go ahead and fabricate the bar. Once the bar is done, then we remade the draft trial again. We checked for the midline, the smile line, the aesthetics, the function. And this is how the patient looked with that of a draft trial. However, we were not very happy with how the lip support was. Because of his surgery, the lip had become taut. So then we went ahead with a round of Botox to relax the lip muscles, and that is how the patient looked post a round of Botox. So this was the transformation for the patient from the mucormycosis, the surgical aspect, to a removable partial denture, and now we are progressing towards a fixed option, wherein we will be giving him an eye-bar supported fixed prosthesis. So with this, we come to an end for the protocol for removable dentures. We'll go ahead and get started with the demo for the design of the complete denture.
बोल देना मैंने
So, as Dr. Kushali sets up for the demonstration for the complete denture digital planning in the software, that is your 3Shape software, we wanted to show the educators here how to implement this in education wise as well. So what we did is we did a certain study by letting the students go ahead and decide certain things on their own. The entire video will be self-descriptive, after which you can ask us your questions. Is there an audio I can connect here? Okay. English. Just before I play the video, I'll just explain what the purpose of this video. So in our university, in our dental school and our other schools as well, we have something called an Edify. So it's technically a faculty development program run by faculties for education. So we chip in a new training methodology. So each department gets a slot every week. So we are repeating about 9 departments and then 6 basic science departments as well. And we have some adjunct departments like cardiology, practice management, behavioral science. So each department gets 1 week, and once the full cycle is over, then we repeat again. So as a part of that, we create teaching and learning methodologies, which we share with the other departments, so that they can also implement ours, whichever is relevant to them, and we also get to learn from the other departments. So it's called Edify, which means that we are educating the educators. Stands as a stalwart pillar in education. Its efficacy lies in its simplicity. Repeated exposure ingrains information deeply within the mind's recesses. This can be deemed similar to the muscle memory that sets in as a part of constant daily workouts. This is the same technique that Usain Bolt incorporates, which led him to make the impossible possible in a short time. So we devised an experiment to establish the same principles into preclinical training. The first phase of the experiment consisted of a didactic session where a faculty member explained about the principles of teeth arrangement with an audio-visual aid. Phase 2 of the study involved a demonstration where the students were given a demonstration of a complete teeth arrangement on an articulator.
insight that repetitive learning produces better outcomes. The next phase of the study involved an examination where the students of both the groups were asked to perform the teeth arrangement for a complete denture within a stipulated 3-hour time to be evaluated by a blinded evaluator. The results revealed that the group of students who performed one teeth arrangement per day for 10 days, that is Group B, had outperformed the Group A. Group B also took less time to complete the examination compared to Group A as shown in the graph. These results reinforce the great effects of repetitive learning. For the last phase of the study, to test the creative skills of the participants, the top 2 students were asked to characterize their dentures. This was at free will. The Group A participants went ahead with manual characterization, whereas the Group B wanted to go digital. They approached the faculty to get a scan of his dentition and replicate it by 3D printing. So they scanned, designed, and custom-milled teeth and set them on the denture base. Surprisingly, the creativity element of the Group B students was also high.
Whatever correction I made, I felt like I was stuck at the same place. This time is monotonous.
Like I was making the same mistake every day and correcting the same again and again. I would not show that much creativity. Like multiple teeth arrangements over 10 days was a very great enough. Each time they did a arrangement, we saw where they made a mistake and how they improved in the next one. This helped us improve our skills greatly.
Practicing teeth arrangement many times has helped us to get to the past. With every new arrangement, we have learned from our previous mistakes and we have corrected them. We got correct habit each time.
So the intention behind this was to allow the students to create their own outcomes. So whenever we insist on a specific outcome, we say that you take this path alone. Usually it's a very closed-end system. And cognitive learning and actually characterization and their own inputs usually come in when they are led for free will. You treat them the basics, which means you go ahead and tell them that this tooth has been set, let's say for complete denture, has to be set in this fashion. Also for endo you would say that this is the access cavity for a classic, the way you open an access cavity. You would be actually astonished by allowing the students to come up with their own ideas on their own cognitive measures. So they can think on their own and give additional ideas. So when we say that this is the only path, it becomes very monotonous. So when you give that open-end system after teaching the basics, we get to learn a lot from them. So that's a way that we had improved this. So this is the initial part of the video was about repetitive learning, where one student, two groups, I'm sure the video is explanatory, I'll just sum it up a little bit. So 2 groups, one group was asked to do one teeth setting for 10 days. Just one, start day 1, give me one finished outcome in 10th day. Second group was start with one on the first day, progress as much as you can and stop. And then next day morning restart from the beginning. So this is, it just popped in my mind that restart, what was it movie again? 12th fail. So we asked to restart. So 10th day, by 6th, 7th day, they were able to finish everything and it was much faster also on their end. So by 10th day, their skills were higher. So that was for the repetitive learning. And then we allowed them to characterize. And we didn't insist on this is the only way to do it. So once we opened the option to them, you can choose anything you want. You can go browse. So we are a source of direction. And then there is a lot of source of knowledge outside. So they went and analyzed their own things that they can customize teeth. They can do characterization with this basic wax up. So we let them do it. So our outcome was quite interesting for us itself. So we never expected them to approach the faculty itself to scan his teeth and try to replicate his own dentition on the denture. So that was something that we appreciated the students a lot. So small things like this actually improve both sides of the education spectrum. That is your teaching and your learning. So that's something you wanted to insist, and I'll let Dr. Kushari take over from now.
So once we go ahead with planning for the complete denture and the designing aspect for it, this is how an order form in that of 3Shape software would look like. So again, on the left hand side, there are patient details and details that you require to feed it, so that each case remains different. Once that is done, then you move on with selection of the teeth and the gingiva for that of the complete denture. So we
What is the name of the software?
3Shape.
What?
3Shape designing software.
Analyzer for alignment.
No, this is 3Shape designing software.
So everything is in that.
Yes, so on my right hand side, if you see, there's anatomy, there's frame, abutment, miscellaneous, bridge, gingiva, removable, model, appliance, and implant studio. So your implant studio is the one where the designing and the planning for the guide as well as planning for implants take place. All the above parameters are a part of the 3Shape designing software, where now we'll be focusing on the complete denture aspect of it. So once you select a particular tooth, in terms of complete denture, we will go ahead with 1.7 to that of 2.7. And if you go under the gingiva category, there is an option for denture gingiva. The first option here is the denture gingiva. Once that is selected, this will all show pink. Then you move on to anatomy, and then there is an option for artificial tooth that will automatically pop up, which is for the denture teeth that are there. And then we move ahead and do the same for the lower as well. We select the denture gingiva and we select artificial tooth. So once this order form is created, then if you have a scanner that is already attached to the system, you can go ahead and scan your upper and lower STL files and scan the GR that is there, or the jaw relation, so that you get the upper and lower casts as well as the jaw relation. In this case, I have already loaded the data, and as soon as you load from the order form, this is what you will open up to. So you will have your upper cast and the lower cast that is there, and you will also have your occlusal rim, which can act as a guide in the placement of the teeth that are there. So once we are on this step, then we go ahead, and the first step, so 3Shape is an extremely user friendly software. Once you start meddling around with 3Shape, automatically you will understand what is the next step that you have to go through. If there is an error, it will never let you go to the next step. It will keep popping an error message until you figure out what the error is, correct it, and then move on to the next step. So the first step here, as it states, is the occlusal plane. So we go ahead with the 3-point occlusal plane placement here, wherein we place 1 point on the posterior region, 1 point on the anterior region, and 1 point again on the posterior region. So this is where you get your occlusal plane. Now, however, it may require somewhat of adjustment depending on the plane that we have. So the system would already generate the plane, but we will have to go around and assess where the midline would come. So these are all the parameters with which you can rotate or you can change the angles. So this is where the midline would be. I can bodily also shift the entire section here, go back to the other side, check for the occlusal plane as well. At this point, the occlusal plane looks slightly tilted, so I can shift the tilt, I can move the entire parameter up or down. And this point is very, very crucial, because once you set your occlusal plane, this is exactly like your glass plate. So on every step henceforth, when we are designing the teeth, or we are moving the teeth front or back, or customizing the tooth position, this will act like a glass plate, and basis on this, as a reference to this only, will be continue with our placement of teeth. So once your occlusal plane is set, we move on to the next step, which is assessing the characteristic points. Now when we go ahead with the conventional denture, we know where the limiting structures are, where are secondary structures, the stress bearing areas are, where are relief areas are going to be. However, with the system, we will have to let it know that these are my limiting structures, these are my relief areas. So very clearly on the left, they would have given the sequence in which we have to go ahead with. So the number 1, it stands for the left side, and number 2 stands for the right side, both for the maxilla and mandible. So here if we see, it says tuberosity 1, so we will be marking the tuberosity 1. Then it says the incisive papilla, so incisive papilla. Tuberosity 2 is on the right, so we mark the tuberosity 2. Then we mark the canine point 1 and the canine point 2. So this will be a reference for where the tooth position should be, where our reference lines for the central fossas are going to be. Once the position for the maxilla is done, then we move ahead with that of the mandible. So again, in case of the mandible, it asks for the retromolar pad center 1. Retromolar, then we move on to the buccal aspect of that particular retromolar pad as well as the lingual aspect of that retromolar pad. Then we go ahead with the central ridge. Any lapse in marking these points now will lead to an error while we move on to the next step. So it is very crucial that you pay attention to whatever is marked on the screen and you go ahead and follow the same order. Then we go ahead and mark retromolar pad center 2, retromolar pad buccal 2 and retromolar pad lingual. Then we have our canine point 1 and canine point 2. So once these points are marked, then we move ahead with the next step. Now we have to define the jaw boundary. Like I said, we need to tell the system that these are my limiting structures. This is where I want the extent of the denture to be. So we take a pencil and we start drawing our points. I'm just going to go a little bit off the margin to show you how we can correct.
So similar workflow will be there in ExoCAD as well?
Yes, it is exactly the same. However, ExoCAD is a slightly more advanced version, so the chances of characterization are slightly more higher and it is a little more technique sensitive. So why we are going ahead with showing you a demo on 3Shape is because at a beginner level, if I go full-fledged with the advanced techniques that are there, then it will get too confusing to start with. Is why we are going ahead and showing you a demo in 3Shape because like I said, this is an extremely user-friendly software and it won't let you progress if there are any errors. It will tell you, it will keep prompting that this is where you're going wrong. So I have arbitrarily drawn, but however, as you can see here on the label region, my margins are slightly short. So what I can do is go ahead and just make those corrections where I can just draw. Just a second. Yeah, we right click and go ahead with something called as a fast edit line, in which you can make the corrections by just drawing and the entire extent would extend till there. So this is something that comes at this point just to let it know the limiting structures. However, later once we are done with the design of the entire denture as well, there is a point where we can make changes to the limiting structure of the denture that we want to go ahead with. So we go ahead and mark our limiting structures. Once you are arbitrarily happy with how the limiting structures are looking, then you can go ahead and do the same for the manually. And you will only connect once you go back to the first point that you have drawn and double click on it. So you will get your yeah, so once the limiting areas are marked or the denture boundary is marked, then you go ahead. Like I said, if there is an error, it will keep prompting that there is an error somewhere and ask you to correct it, and then is when we can move forward. Sorry for the glitch.
Hello. समझे सर? मुझे वेरीफाई हाँ मैडम बोल रही हैं
Reproduce the width of the circles as well.
Sorry?
It will reproduce the width of the circles as well.
Yes.
Okay.
हेलो बीच वाली तो नहीं तो या तो साइड होगा या तो उस साइड होगा या इस साइड होगा ये फिर धुंधला आता है सब बहुत जब हाँ लगा के देखा था हाँ तुम्हारे धुंधला आता है यहाँ कुछ समझ में नहीं आता ब्लैक स्पेशल
There seems to be a glitch in this. Till I figure out, Dr. Naveen will get started with the root supported part of it.
नहीं इसमें नहीं होता सर ठीक है ठीक
So the next part, until the CD glitch gets corrected, and we go back to that. We didn't want to waste time. So
So for inlays, onlays, crowns and bridges, the design part is very simple. So like we showed you yesterday, where you start, go ahead, mark the margin, and then the system itself gives you a crown, and you adjust and adapt the crown through the process of your designing. So what are the clinical, to align the clinical outcomes or the clinical procedures along with the laboratory procedures? This is the next part where we talk about crown and bridge, smile designing. We talk about full mouth full mouth crowns also. We show you a rough idea of how to design and what are the clinical things that we need to make sure such that the designing outcome comes out best. So this is our preoperative image, and obviously the first step will be tooth preparation. You have your diagnostics done already. You have all your temporary mock-ups ready. You go ahead with tooth preparation. Once the tooth preparation part is over, then you do a pot packing. Invariably, if you go for a digital impression also, we recommend pot packing for sure because subgingival margins are not covered under your intraoral scanner. So if you have a very deep subgingival margin, we always recommend to go a hybrid protocol where you start off with your tooth preparation, pot packing, impression, and then scan your models and go with the digital workflow, which I'm sure most of the cases here are being done. So once that is over, we made an impression and digitize the models. Once the digital model is created, we start ahead with the designing part in 3Shape. This is 3Shape software. XOCAD also will look very similar. So once the design is ready for approval, so here we have gone with the coping pattern for this. Since it's an anterior, you can either go for a label cutback or a full coping. Monolithic will not be the best case scenario for this. Also, if you have a multi-layered blank, you can go ahead with a full morphology design and mill it off a multi-layered blank. The problem with the multi-layered blank for anterior cases is that the entire surface of the label surface will not be in the enamel grade. Only the incisal edge will be enamel grade. So the tooth is a three-dimensional structure, right? So the entire labial surface is enamel and underneath is dentin. But the blanks are categorized as enamel at the edge, dentin in the middle, and cervical, deep dentin and other colors they have. So it's better to always have a finishing technician if you are going for full morphology multi-layered blanks in practice. Or the other scenario will be to go ahead with your pre-shaded blank, which will cost much lesser, and do a label cutback and just layer the label surface. That way you can characterize all your dentin layer and your enamel layer throughout your label surface. So once the design is done, we end up doing a nesting process. So like I told you, zirconia, you can nest about 25 to 30 crowns in one shot in the blank. So always try to club cases and try to mill them because the calibration part is much faster if you do it all together. Otherwise, the machine calibrates itself multiple times if you go ahead just milling 3 crowns, 4 crowns, and then again the next day you're milling 3 or 4 crowns. So try to cluster them so the designs should be ready. That's one reason why we are insisting on the post-grads to finish the design. So the protocol that we will insist is student does the prep, makes the impression, scans the model or does a digital impression and has a digital model on ready, design, and then there should be one person for milling alone. You should have your technician can actually do the milling process and post processing and give it back. This is his job. So that his load also will be much lesser. He will be in the manufacturing end more than the designing section. So as dentists, I think we have like 10% higher edge at least. Of course, with the experienced technicians also can come up with greater ideas. But the 10% edge that because I have done the preparation, I have known, I know if I'm tilting the tooth or I have made sure to keep a connector much narrower or much wider. So I'll be in a position that I can fix it much better than the design process. Once the design is done, we give it to the technician or the technician can cluster all these designs. So PG1, PG2, PG3 and do a 1 milling cycle per day or 2 milling cycles per day as per the requirement. Don't try to keep 4 units per day, 6 units per day and then keep training because the machine runs its life. So like how your battery keeps running out, right, in your phone, which means that if you zero down to charge and then again charge, the cycle goes off, right. So every time you restart the machine for calibration, it's a cycle. So the belts are getting used, the drills are getting tested. So it's a little bit wear is happening at that situation as well. So once the nesting is done, it will take about like 6 hours for a full blank of zirconia drill. The technician can cut the screws, finish off the extra screws and center it and give it back to you for your clinical work. So as clinicians, we need to do definitely a coping trial. So for all our cases in our university, we have a coping trial mandated, be it a single unit crown or a 3-unit bridge or a full more case. So the other way, since you have an in-house facility, it shouldn't be difficult because there's no transit period here. Like you can get the coping trials previous day, do the coping trial in one day and send it back to the lab on the same day for the layering process if it's an anterior case. If it's a posterior case, do a pre-case trial and go ahead and sorry, I haven't gone to the next slide. So we do a coping trial here and we make sure to take a radiograph to check if everything is seating in place. This is always done for all our cases. We never miss on the coping trial aspect for any case. Then your ceramist can do the labial layering if it's required, the entire full morphology layering, and then he can finish the final restoration because now your ceramist has more time to do finishing touches rather than sitting and generating contacts, layering everything from buckle to linguals. So you can go for cutback designs where he can characterize more with stains and everything. This is an off the internet picture we just want to show because this we didn't have a full laboratory workflow for this. But this is how the patient ended. We were able to, but everything happens in house for us. So that's the advantage, which is something that I would definitely suggest here for crown bridges and even your long span bridges and your metal ceramic work as well. Because now you're doing zirconia. If you're doing the same situation with metal ceramic, the protocol will be to mill the design that it's the same. There's no changes to the design. From there, instead of sending it to milling and then directly inserting in case of zirconia, you will do a milling of wax or a 3D printing of a resin, castable resin, send for casting and get it back. Also, with that being said, your wax technician, that is your metal technician who is doing casting, who is making patterns, then investing them and casting them, he will not have the he will not have the requirement to sit and physically do a wax or adjust connectors on the cast. He will have ready-made printed or milled wax ups which he can cast directly, like the ones I showed yesterday. He had a green color printed resin that will help with him. So he can focus on the actual finishing aspect of the restoration rather than the design aspect of the restoration. Now, because that we have moved one step ahead. Right. So next part will be the smile designing. So this was a pre-operative case situation, and from here we had gone all the way here. So we will show you a workflow of this, which is a clinical and laboratory workflow as well. So this is the pre-operative image before starting. One thing you would notice that we emphasize a lot on photography and documentation in our institution as well, and we compile them on a every 3-month basis. So we don't print the PG program book at the end of the program. We make sure to print it every 3 months. Just the binding part will happen once the last case is completed. So with photography, we have some training professionals in our college who attend this itself. So they train on photography. I think it will be a very good skill to acquire because showing is believing, and until you document your stuff, and no one's going to appreciate that this is the only way that it can be done. Right. So then that's your occlusion for upper arch and lower arch. Here we have done only the upper anterior veneers. So that's in protrusive. This is a protrusive photo of the patient. This is in centric. This is a lateral smile view. So before preps, we make sure to mark your lines for the preparation. Here you can use either with skill, depends on your skill, you can either go ahead straight preparing or you can use depth cutting drills to finish off the initial depth cuts. Once the depth cuts are done, then you can go for the final preparation for your veneers. Here you can see that this is a lapping kind of a case. We haven't done a window preparation here because we had to modify the incisal edge. So anytime you have to do a incisal edge modification. If you can see this picture, the incisal edges are chipped off. So for any situation where you want to change the length of the incisal edge or you want to modify the characteristics of the incisal edge, you will always want to do a lapping kind of a preparation which laps on the lingual side. We had a digital design ready for it, for this case. I will show you the protocol. And we printed a model. So for veneers, you cannot mill temporaries. You cannot print temporaries and keep because they are ultra thin, right? And with tooth preps, it's much easier. If you pre-print a temporary and keep it as before the patient comes, there will be modifications possible because you are at least ending up doing about 1.5 millimeters reduction on all sides. So our thickness that we keep for the temps is 0.8 shell thickness, so that the interface will adapt anyhow and we can do a redesign. So the next thing is that once you for veneers, design your structures, facial structures, that is your smile and aesthetics. Then you make print the model and you make an index of the model. So this is the temporaries that we deliver on the same day of the preparation. So this is with a classic putty index with an overlay. So the other thing you can do is pre-preparation temporization and check, which we call it overlay temps. So instead of once you, let's say you have addition required, not subtraction. Let's say there is spacing in the anterior zone and you have a situation where you are going to give veneers to cover the spacing. Of course, you're going to beautify the incisal edges, you're going to beautify the label surface with all your design part. So for those situations, we have something called overlay temps, where we design the structures, that is your anterior smile designing procedure in the system, and we go ahead with something like this. So this is the pre-operative. We go ahead and do your smile designing for the picture. So in this situation, from the scans, you want to take one? I'll read this and then you can. So once your scans are done, we do your pupillary line, midline. So there are set instructions for photography in each system. So there is a specific distance and
This is software are
this
using
is exocad.
execute.
Yes. 3Shape also. So technically, smile designing is crown and bridge. Okay. The only thing is it has a photographic addition to it. That's it. So the margins you mark will be the same like the margins you mark on your tooth prep. The margins
This is
you
available in 3Shape as well?
yeah, that's what I'm trying to tell you. Anterior crowns with photograph there is smile designing. Essentially that's it. The only thing is the proportions of the photos should be same, which means if you are taking a frontal photo of the patient at 1 meter, you should take a lateral photo also at 1 meter. So that set distance is not changeable. So what we do in our photographic studio, we have the patient centered in one place, so obviously that's not going to change. And we have markings on the tiles. This is 1 meter. So on the frontal, on the diagonal and the lateral. So that should be similar. Otherwise, your proportion of your photos is going to be different. And we don't change the camera settings between these two photographs for our patient. So here you can see that we have eliminated that area or technically marked that area where we need to customize the design. And here you can see that we have gone in and given the anterior cosmetic corrections. So this is your rough plan. So this is the part that we took our index at. So this model we printed and temporized with that model only we made an index of, and we temporized that model with the index. Okay. So for the other thing I told you, the overlay where you don't have to prepare your adding material, you just roughen the surface and then adding. So you can do something before prep to show the patient that this is your outcome. And there is a technique in Gallup Urel's book which says finish the restoration on the patient first and then you can decide the tooth prep, because once your overlay is done, that is my final position that I want to stop at. From there, you prepare the temporary on the patient and reach the tooth to the depth that you want to. So that way you're not over prepping at any point. Which means if you're still at the restoration, as you're preparing for the veneer, and you're still at, and you've done about, let's say, 1 millimeter, and you're still trimming restoration, you haven't reached the tooth, which means that tooth doesn't require prep. So that is one overlay temp technique that we insist on. But for this case to finish, so the smile designing, so initially core things is photography. Second thing is you mark your smile line, that is your lip support and your interpupil design and the midline for the patient, and you start designing the extra. So these changes essentially are the same. It's just a photo overlap. You have to understand that the model, how it looks for a single crown or a 3-unit bridge or a 6-unit bridge is the same. You can eliminate the photograph or add the photograph to see how it looks in the patient's mouth, face. Sorry. So this is the final design that we decided to process, and we went ahead to etch the teeth after once the design everything was ready. All our veneers we make sure to cement under rubber dam to get enough retraction, and because you're using bonded resin restorations and using bonding as a protocol, so it's always best to isolate the rubber dams. You don't have to do gingival push in that area because that you can manage with drying. So that's the post-operative finish. Intraoral view, and this is your smiling view. So to start off from there,
Which veneers are
these are Emax.
Emax?
All veneers almost are always Emax. The other option that you have for material science, if you're talking about materials, always veneers are Emax because they have glassy structures. So you're not changing the shade of the tooth per se, you're changing the structure of the tooth. And if you want to change the shade of the tooth, we would not recommend you to use Emax. And if you have anterior teeth or any teeth for that matter, just root canal treated. Definitely Emax is not the solution for that tooth. If you have, there's another protocol for that which also I'll explain. So if you have a root canal treated teeth, the most commonest thing that happens over years is color change. So if you use Emax restorations post prep, let's say a patient comes in fractured tooth, pulp exposed, you do a root canal and you do Emax restoration. What happens is with time, as the tooth color becomes darker, the restoration color also will just shadow the tooth color because it's glass. It's nothing but glass. So that's one reason why we don't use Emax for non-vital teeth. That's one thing. However, if you do a bleach for the teeth, you do a pre-bleach even before it becomes dark, right? Not very strong bleaching, but at least mild bleaching. Then you can expect it to not change color for at least 10 to 12 years. The third option here is if you feel that I still want to go with Emax and I want to do the maximum outcome of this. Some parts the tooth is discolored, the others are still intact, and that discoloration is not because of the pulp procedure. Let's say you have tetracycline stains or something. So if you prep tetracycline stains patients and you put an Emax on them, it will still show the stains through the crown. So you can use opaque cementation materials. So you have A1 shaded resin cements, A2 shaded resin cements. In that you have a translucent resin cement. So if it's a vital teeth, always translucent. If it's non-vital teeth or where you have done bleaching and you still want to go Emax, or a patient with AI, aneurysm imperfecta or DI, where the internal color itself is yellow. So then if you still want to go Emax crowns or veneers for this patient, go ahead with pre-shaded resin cements. It's an A1 shade, which is technically now the restoration is going to reflect the cement color, not the tooth color. So that is your indication for that. Any other questions at this point for material? So otherwise, if you feel that the reduction is more and you feel that there is a lot of work to be done on the lingual surface of your restoration as well, we wouldn't. See, veneering is a very niche procedure. So there are set indications which it can solve, but crowns can solve everything. So we have to agree to that. Preservation of what remains is our always priority, but when it supersedes uh, aesthetics, we never allow it. We choose aesthetics over this because these are aesthetic procedures. So let's say I have a case where I have some amount of lingual enamel left out, and most of my thing, I don't want to go to do a veneer that case. I want longevity of my restoration. So I will do a crown. That's to do with the preparation aspect. With the material aspect, zirconia gives you more changes in the entire texture of the material. Your Emax cannot give you textural changes because you can add mamelons, you can add a lot of things in zirconia with the coping state, but not in Emax. Emax you can characterize from the outside. Zirconia can be a core characterization. From the inner surface, you can start building the way you want to. So you can choose your material according to the requirement. There is the lateral view of. So this one part also where we leave our students to do their photography. So there are set photos for our templates that we ask them to keep. But we also, in their final PG program book, we also let them take photography of anything they want and put. So there's one small section for their own stuff, like for what are their hobbies and what is their basic skill and how they want to improve in the next 5 years and their work with photography. So this photo may not be needed for documentation at all, but it makes a really big impact when seen. So that's one thing. You would assume that this was an error, but it was not. We didn't have to zoom it. The intention was to take it like this to see actually that it's same patient that we have gone ahead and done it. Right, so that's the difference, and that's the patient post-operative. Okay, so things to re-emphasize is smile designing is same as crown and bridge. It's nothing superior. The only superior thing is you'll be able to see the outcome, the patient's photo slapped on it, on the design. So as you change the design, if you want to work on the design, you can work on the design with the photograph only the exposure part of the teeth, the width part of the smile coverage. But the margin selection, everything happens the similar way how will your crown and bridge work.
So you're doing this in ExoCAD and you're not using a specific smile design software like DSD?
No, this itself has smile designing, it has a smile designing option. So when you choose smile designing, it will ask for upper cast, lower cast and pictures. So once you slap the pictures, it will take it in. And the changes that you do on the crown bridge structure, and then you had seen that we were able to hide the teeth, hide the model in sections, right? Same thing. So if you open up the full model view, you can see the face in the model. And the changes that you make here will appear here when you darken that, you increase the opacity of that. That's the thing. So next is I'll finish the tooth supported part and we'll go on. So this is the last part of the tooth supported. Then we'll go back to the removable designing and then we'll come back for our implant work. So full mouth rehabilitation. This is our patient to start off with. So we always make sure to do photography like I told you. And this was a case of attrition, so we made sure to do a full mouth rehabilitation for him. There were erosion spots as well. This is the occlusal view which demands a full mouth rehabilitation. There is erosion on the lingual part of the upper anterior. There is wear and erosion on the lower posterior and upper posterior. Sorry. So we went ahead and did a tooth preparation for him post our preparative work. And we went ahead and did a full mouth impression with cord packing. Cord packing again mandated if you are doing physical impressions or digital impressions, because the subgingival margins will not get covered with your digital impressions. So that's the design part of it. Here we have done copings for this, and after the design is ready, we send it to our lab for milling. Here since we are doing zirconia, we are going straight milling, and we've got the copings done. We make a coping trial X-ray. Once for full mouth we take an OPG, for sectional teeth we do IOPS. And once the seat is verified, so we make sure to see the distal part of all teeth, and to see margins, how they are fitting, and because some of these preparations are substantial, because they demand substantial preparations because of the erosion on the adhesion part, where the teeth structure is very small, so you need to gain height. So you have to go substantial or do some osseous procedures if required. And once the restoration is ready from the lab, we go ahead do this trial and then glaze the restoration and fix the restoration. So that's patient pre-operative to post-operative. And this also allows, this is so like how the veneer, the student who did the veneer design did a integrated photography of his own. So this student has intentionally done this to see how these teeth are following golden proportion and why it looks the most aesthetic. So these are very small things that we can do to improve on our presentation skills for your competitions, for your national level papers and your publications as well. So this is one thing that we always emphasize on. So I will leave the podium to Dr. Kushali to continue on this. So it's a very small section, it's a very fast process for the complete denture. We will show that and then we'll move on.
Sorry about the glitch that happened earlier. I had to go back and redesign everything. So there are times that something like this could happen while you're doing your design. There may be chances that the entire project might crash and you might have to start all over. One drawback with that of digital dentistry. So we stopped at the boundary marking. Once the boundary marking is done, then we move on to the insertion direction marking. Now since these are ideal casts, we don't have any undercuts that we should be worried about, but this is how the path of insertion would be marked, and you set it from this region called set from view. Once you're happy with it, we move on to the next part. And if you see the yellow and the red markings are all the undercuts. So sometimes if you want to provide a favorable undercut, then we change the path of insertion accordingly to provide a more favorable undercut for our prosthesis. Once you set an undercut, then the system on itself will give certain relief areas. So this is the wax knife. Similar to how we manipulate wax, the system also provides the settings of something called as the wax knife setting, where you have an addition, subtraction and a smoothing tool. And you also have the radius, the diameter in which you can add material. If you can see, this is the diameter in which I can add material, and there is the depth to which I can add material. So if I were to provide a relief area here, say I wanted to provide relief near the papilla and the mid-palatine raphe, this is how the wax will be added. In a similar case, if we don't want to provide any relief, then this is how it will get removed. Depending on the depth, you can add or you can remove the wax. So once we are happy with this step, since these are again ideal casts, we don't have to worry too much about the undercut or the relief areas. Similar thing happens with the lower arch as well. You mark the insertion direction. The system on itself will generate an insertion direction, but if at any point you feel you want to make any changes to that of the insertion direction, you set the insertion direction as the occlusal view, and then you go to set from view. Once that viewpoint is selected, it will change the path of insertion accordingly. Once you are happy with the path of insertion, we move on to the next step. Again same, if you want to provide any relief area or you want to remove any relief areas, then all those happen here with the help of the wax knife tool. Once this is done, then comes the teeth setting part. So there are set libraries that are there in terms of, because I have already finished designing this, just a second. Taking a while to load.
there's a loading line there on the left bottom of your screen there. So after every step, there's a small loading process that it has, that the system itself does. So this is the AI backing of the 3-shape system itself. So at this point, it analyzes for errors if there are any, and it will prompt you that fix this before you go to the next step.
Sometimes if you have a really large file of the STL, then it slows down the system. So it's always better to either have the scans of only the required area that you are pertaining to design, or to cut out the scans in the first step that is provided. So after we are done with the insertion direction marking, this is where you land up on, which is the Smile Composer. The provider, so there are different libraries of teeth that are available. However, these need to be downloaded from their official site, and some teeth set might have certain charges that are applicable for acquiring the teeth set. So the available one right now is this, but based on how we go ahead with a conventional assessment of a teeth set, how we select the anterior tooth size, form the similar manner only we go ahead with that in the digital ledger as well. Once we are happy with the teeth set that we've selected, then there are certain options here that you can use. So once I'm happy with this, I'll just go ahead, apply the teeth set that is there. So at this point, sometimes if say with printing or mailing, you don't want to go ahead with the library that is there. The same library's teeth set will also be available with your local teeth set material provider. So you can just get that, get the denture base printed or get the denture base alone mail, get those individual teeth and then glue them onto the denture base and then make it look more aesthetic, because the finish that the teeth set that are available in the market have, no matter how hardly polished or glazed the indirect composite as well, that finish may sometimes not come. And if a patient is somebody whose aesthetic demands are of a higher category, then that is one option that you can go ahead with. So select a library that your local provider has, go ahead and finish the designing so that you get the gingival contour of those tooth pattern onto your denture base, and then collect the teeth set and then individually cement onto the denture base. So once we select the tooth that is there, the tooth library, then there are these red and blue balls that are there that will help me in positioning my teeth set. So if you see, I can move my teeth set left and right, I can move my teeth set up and down, I can rotate it to any axis. Till this step, everything is similar to that of ExoCAD. However, from this step is where ExoCAD gives you the full freedom. Like how in my 3-shape I am restricted to only move in this horizontal axis, in this vertical axis, maybe rotate around this region. With ExoCAD, what happens is it's full freedom in all 10 directions. You can go move around everywhere. So a person who's just starting and getting into the basics of the movement of these teeth and how the mouse controls the movement, how the haptics work in and around, using ExoCAD is going to be slightly trickier. And after a point, because we are so used to the conventional method of teeth setting, this will start becoming very, very tedious to continue, and then we will give up on designing and continuing with the dentures. Because when we got started with designing digital dentures, that was our first reaction. With the first 2 cases, I think we were struggling left and right, and it took us almost 10-12 days to just move around the teeth that I'm so easily able to move right now. But to just learn this and understand how do I move the teeth set, it took a long learning curve in 3 shapes. So in ExoCAD, it is twice as hard as it is in 3 shapes. So this is the movement of the entire arch together. So we have the upper and the lower arch. So I can move the entire tooth set to wherever I want to, whichever occlusal plane I want to keep it in. But we also have our jaw relation that is done. So we place the occlusal anatomy arbitrarily accordingly. Once I am happy with the position, I am happy with the midline, then if there are any individual corrections. So as such, the system gives it to you in balance occlusion only. But however, we have to remember that there has to be some human intervention and we just cannot trust AI at all times. So individually, it is always better to check the tooth position as well as to check for occlusion, because sometimes there may be errors in the same. As we can see here, my occlusal rims are slightly outside, whereas the teeth set that is provided is slightly towards the inside. So if I were to print or mill this, the buccal corridor in my patient would get slightly hampered. So that is why your occlusal rim comes into play. Only if you have perfect occlusal rims, wherein you set your buccal corridors properly, you set your occlusal plane, you set the protrusion of the maxilla, you set the lip fullness, can we go ahead accordingly. So now with this individual tooth set, if you see here, this was for the group. This here has a small tooth bar that is there. And like I said, in 3 shape, it will tell you that this is individual setup. You move your cursor to the area that is there, this will tell you this is for occlusal plane adjustment. So at every point it will guide you as to what needs to be done. No matter you are a beginner or an expert, you can just go through it again and then continue. So if I were to make any adjustments to the tooth, because there are some patients who are demanding and they come and say, I want the canine to be slightly more prominent, I want my laterals to look like how I had them previously. So in that scenario, you can just zoom into one tooth, select the tooth and make the movements in that. However, if I wanted to mirror the movements in the same, then there is a mirror option as well or a symmetric design option as well. On selecting that, my laterals on both the aspects or any tooth that I select would move in a similar fashion. So at this point, I can make individual tooth corrections. On my right hand corner, if you see there's a panel, this panel allows us to navigate between the different scans that we've taken. So there is one for the upper scan, there's one for the upper teeth set, then we have one for the GR. So you can move around this cursor at all points and then you can arrange the transparency levels as well and move ahead. So at this point you can set the denture teeth accordingly. The principles remain the same as that of the conventional dentures. So I would move the canine up a little bit, say if I wanted to rotate, bring out the canine slightly more. And at every face, so at the labial face I can rotate it at this angle, I can make the rotations at this angle. But if I were to change the angle in which I was working, then now I can rotate the tooth in different angles. So if you see, because the symmetric design is still on, I am able to make the tooth position corrections. However, now the canines are too flared out, so we will slightly bring them inside. And this is how, so like I said, the occlusal plane, the first step, so this is your glass plate. And now you go ahead and arrange your upper teeth according to how you would arrange them conventionally based on your glass plate, your incisal edges of the central incisors lie flat on the glass plate, your canine tips touch the incisal plate, your laterals are 0.5 mm above. You do the same with the posteriors, and once you are set with the upper is when you start with the lower. So you can make corrections accordingly, or there's a slightly shorter way as well. So once you're set in placing the uppers according to the glass plane, you can just right click and you can click bring to contact with the antagonist. So what it will do is automatically it will bring the teeth into contact with the antagonist, it will bring it into contact with the mesial contact, it will bring into contact with the distal contact as well. Once you are happy with how the teeth are looking, the teeth positions are fine, then we move ahead with the next step. These are collision lines that sometimes they end up showing because we have not set any connectors, so they may end up showing collision lines. If we were to set a connector or if we were to connect them together. Or if we were to do the same, these wouldn't appear. Once we are done with this, then we move on to, again like I said, while marking the limiting structure, if there are any changes that we would like to make to the denture base, it is at this point. And if you see on the left hand side, there is gingival aesthetics or gingival festooning that we normally see. So there are different categories of gingival festooning that is available. We have a delicate category, then we have a natural category, and we have a slightly intense category. So on going ahead and selecting on those, there are certain parameters that are available here that you can normally also customize accordingly, or if you wanted to remain as such that the system provides, you can have the system provided access as well. Somebody was mentioning about the base thickness and the depth, whether the sulcus depth would get recorded. So those changes can be made here with the base thickness that is there. Say somebody wants a thinner base, a thicker base, all that customization can be provided at this region. And the relief areas. Like I said, while marking the anatomic points, the system itself will know that after marking certain points, these are my relief areas. So in those relief areas, apart from the wax blocker that you want to go ahead and do, if you want to still provide a more relief to those particular regions, then you can go ahead and customize these regions as well. Once you are happy with the festooning here, we move ahead. So this is the gray composition that is there. Say if you were going to mill it, then your 5-axis machines also would go to a certain degree only. So if the undercut was to be huge, then sometimes end up removing a lot of material, or sometimes it would end up removing less material. You might have to make certain adjustments once your dentures are produced. So we go ahead and give a yes for the denture drill compensation as well. While designing this, I'm not going into intricacies of the teeth set and the how the principles of tooth placements have to be followed, because we are running short on time and the system will take a time to load everything. So I'm just going through with the scenario.
Meanwhile, I think other options on how to maximize on just making the denture base from the digital part and using the custom read set. So Ivoclar has something called Nathostar. That is a read set from Ivoclar, and Ruthenium has Acryrock. In Acryrock, they have a digital library. So either you can download it from the Acryrock website for 3Shape, or you can ask the 3Shape provider to give you a link for the Acryrock downloads. So essentially what you'll be doing is you'll be the library that shows in the system will be very similar to the ActiveRock teeth set you choose. So if you choose A18, B39 from the commercial teeth set, that ActiveRock library should also be there in your system. So if you choose that in your system, you don't need to print the teeth separately. You can just buy that teeth set and cement it onto this. So Ivoclar has definitely one. It's called Nathostar. ActiveRock, Ruthenium also. Ruthenium's ActiveRock is also available with digital thing. So you can ask this provider or the Ruthenium website. You can go and download the libraries from there.
So we see now we have the denture that is ready, the Ginjava is customized. But at this point, if there are still certain customizations that you would like to make to the pink aesthetics of the denture, then there are certain tools that are available here. So this is just like your wax knife. You want to go hard with the characterization, or you feel that the system has given a very intense characterization and I want to smoothen out based on the patient's aesthetics, then this is where you can do the same. You can say in the canal region, I want the bulb to be slightly higher, so then I can increase the bulb, or I want to cover the ginjava, cover the tooth with the ginjava, can do the same. In certain regions, I want to show that there is some amount of recession that has taken place, give it a more natural looking appearance and not make it look like a denture. Then at this point, you can make corrections to the denture ginjava aesthetics. Once you are happy with this, then like I said, you move on to the next. There are different tools that are there. These are pre-manufactured measurements that you do not have to make any changes to. So these are just to make sure that you recheck them, and if everything seems fine, then you move ahead to the next step. Similar thing happens for the lower cast as well. Once we are happy, so there are different tools here, like I said. One is a morphing tool. So this tool will help in pulling or pushing an entire region accordingly. So the spray tool is just like your wax knife, wherein you take drops of wax and you keep adding or you keep subtracting. This tweezer-like tool is to just hold and pull a particular region or to push it back. Again, there are different depths and different radius at which this can be functioned at. So if I were to increase the dimension, it would pull on a whole larger area of the material. And then once we are sorted with the customization, we move ahead. We check for the pre-manufactured settings that are there. Once we are happy with the same, and this is how the teeth set is ready. So in your order elements, because we've given ginjava from 3/7, so the denture ginjava is going to be a hole for the upper and the lower arch. And the teeth, because we've only given single teeth, we've not provided any connectors, so it will show as single tooth. If you were to connect them using the connectors, then it would all be connected together. With this, we come to the end for complete denture workflow.
Just a second. Before we break, the smile design is digital workflow on Exocad. You can just take a look. So I have shown you the clinical outcome, and I have shown you pictures of the digital screenshots. So this is the actual changes that can happen in the software itself. After
So
this,
with
we
the-
can break.
After putting implants?
Removable and then implant. Cast partial. One cast partial denture demonstration, like how complete denture was, and then.
So with the digital smile designing, like ma'am was asking DSD will only give you a 2D output that it can show to the patient. That cannot transcend into a temporary or it cannot transcend into a final prosthesis. In case of 3Shape as well as ExoCAD, the additional feature here is that you can add pictures and then customize based on the principles that are there of the smile designing. Say you take the interpupillary line, you take the lip line, you take the midline, you take the incisor line. So all that. So the first step here on the addition of the picture is going to be that, so with 3Shape this is more easier because like how it showed us points in the complete denture that mark the tuberosity, mark the canine point, mark the central ridge point. Similarly in 3Shape in terms of the smile designing, it will prompt you, mark the interpupillary line for right eye, for the left eye, then it will on itself draw a line with you. Mark the midline point, so it will then draw you the midline. You can make minor corrections to it. However, in terms of ExoCAD, since it's a very, very advanced software, you have to be sure with the principles of smile designing. You need to know that these are the regions that we need to mark, these are the lines that we need to consider. And with that, then you can go ahead and mark the positions that are there. So if we see here, we have done a virtual wax up for the patient, wherein as soon as you put the picture onto the designing software, it will give you a prompt to remove the lip line, because only if we remove the existing teeth, we will be able to assess how the teeth look. So this is how it would end up looking, wherein you remove the teeth that are there. Once that is done, then you will have your jaw scans that are there. So this is how the patient's teeth were, and this is where we start from. Apart from this, the picture holds no other importance in terms of your designing. Your designing is going to be similar to that of the crown and bridge. Exactly how we had seen yesterday to design a single crown and go ahead with the FPD is how we will be doing even for the wax up as well as the veneer also. Once you're done, so the ExoCAD system on itself has these smile creator helpers. So if we see the golden proportion, we go ahead and we mark it accordingly. In this particular patient, there was a midline shift. So to correct the midline shift, then different aspects will continue. And this is how the merged part of the final design would look like. One issue with 2D pictures is that you cannot assess the depth of it. So this will all look very plain. This can be rectified with a facial scan, wherein you incorporate the facial scan into the designing software, and that would help us in assessing the depth that is there. Because with this, as you keep moving, you will not be able to assess whether this is how it will look in the patient's mouth. So once you are happy with how the anatomic wax up was looking, you can go ahead and finalize this into a model. And this is how our finished model for the temporaries was. Using this, the next step for the veneer preparation and the impressions and the final design was carried out. One advantage of doing a mock-up with this is also that once this STL of a mock-up is generated, this can then be superimposed to your final impression as well. And this, once if the patient has approved these temporarily, you can just go ahead and merge these with that of your final impression models or your final impression scan, and will make the workflow even more easier. So that we can take for tea.
So we take a 10-minute break, 15-minute break. What's the tendency?